Hello, everyone. This is Mary Kurek with Frontrunners Innovate, and I have innovation on the table today. So it's very appropriate that we be talking to two innovators, and in same space but different. And the gentleman that we'll talk to first will be Atif Zafar. He's my co-host today, and Atif is serial. We were just talking about a serial entrepreneur, serial investor, serial advisory board member, and founder. All in the area pretty much of healthcare. There's some computer technology sorts of bits and pieces in there that he's founded in terms of companies that are startups doing some amazing things. And we'll let him talk about that in a little bit. But Atif sits on my advisory board, and I've known him for a few years. And so some of the innovations that he's brought forward are life-changing for people around the world. So we'll talk about that. The other face that you see here today, Ehsan Vaghefi. Let me see if I say it right. Vaghefi.
Yep. Yeah, that's correct.
Ehsan, I had Ehsan right. I had to look up how to pronounce this. Ehsan Vaghefi. And Ehsan is usually in New Zealand. Am I right? And
correct.
Yeah, and where this company called Toku Eyes was founded, and he is a co-founder and the CEO of that. PhD in bioengineering and 8 years collectively with that, and working in ophthalmic imaging devices. And so that should get Atif's attention right away. He likes device stuff that do. So what drew us to Ehsan was a posting on LinkedIn that had to do with how they've got an innovation now that can use retinal scanning to be able to, if I say this correctly, hopefully, to be able to diagnose or pre-diagnose, if you will, some really, let's see, just, life-changing sorts of things that happen in the human lifespan. And one of those would be cardiovascular disease, if I've got that correct as well. And, and I think I picked up on the fact that there could be some diagnostics having to do with diabetes and some of the issues that come along with that. But we'll find out more about that. I don't want to pretend to be a medical professional. That's Atif's job. So I'm gonna let it go at that. Let him explain more about his background and what he does with Toku Eyes. So welcome, Ehsan. Welcome, Atif. Thank you for being with us. Yeah, so let's start with you, Ehsan. Tell us what brought you into the work that you're doing today.
Well, that's a very good question. Let me start from the beginning of my story. So beginning of my story is about 1957. And if that sounds old, it is.
Don't say that. That's the year I was born. Okay. Don't say that. I'm not old.
So 1957 is when my father was only 4 years old. And it was the same time that he went blind. And the reason he went blind at that age was because he had an eye disease that could have been prevented if it was detected. But my grandfather was just poor and didn't have the means to take my father to see an eye specialist. And he went blind. The second part of my journey obviously starts when I was about 4 years old. And I got to start to understand that because of my father's involvement with Blind Association, I started to understand that almost all of my friends were either blind or had a parent that were blind. So all of these guys are part of the Blind Association. I grew up with that sort of cohort of people. And again, sort of jumping ahead another, I want to say 20 years, when it got to sort of university education, I knew I had to do something about blindness. That was my passion all time and throughout my life. So I never wanted to become a clinician. I could, but I never wanted to, because I thought that, similar to Atif, I guess, I thought a clinician can only help so many people as they have hours in their day. That's your limitation.
Well said. Yeah.
Whereas with technology, you can scale it up and you can help so many people. So I graduated, my undergrad was in my home country. I was born in Tehran, so I did my undergrad in Iran. I moved to Australia, University of New South Wales. That's where I did my postgrad degree in bioengineering. And during my postgrad, I was focused on artificial retina. So these are little electronic chips that you can put in the back of Some was retinal that, the retinal can be disintegrated and not function anymore. But the idea was these electronic chips connected to a camera outside can translate the image back to the brain. That work is still ongoing at University of New South Wales. So that was my sort of postgrad master's degree. Then I moved to Auckland, New Zealand, and I picked up another PhD, which was just about looking at innovative technologies for imaging the eye. Mm. And during my PhD, I started thinking about, what we can do about early diagnosis. For me, it's all about, I don't want to be the ambulance at the bottom of the cliff, right? That didn't help my father. That's not going to help many people. I want to be the person who can say, as early as possible, you got a problem. Somebody should be looking at you. So that's what I wanted to be. Yeah. So I finished my PhD. During my PhD, I developed two novel imaging technologies. One of them was using MRI, and it was looking at perfusion of blood in the eye, non-invasively, and it could quickly tell if someone has a sort of blood flow problem in the eye that can later on lead to vision problems. So that work has been adopted by a couple of commercial companies. I'm very happy about it. Then I became an academic, essentially. And for the past, I want to say 12, 13 years, I was an academic teaching and researching at the University of Auckland. Although my background is bioengineering, I've been teaching and researching at School of Optometry and Vision Science. That was where I naturally sort of fit in. And during the past few years, I sort of stumbled upon really artificial intelligence and the fact that artificial intelligence can automate a whole lot of things. So about 3 years ago, I was in a conference sitting next to my now co-founder, and my co-founder is a retinal specialist. He's the lead ophthalmologist in New Zealand. He's overseeing the entire diabetic screening program that we have in New Zealand. New Zealand is a sort of a public healthcare system. Everything is free for everybody, unlike the United States. And so he's leading the diabetic screening program. We started chatting, and he told me that a lot of people go blind in Australia and New Zealand, although we have a public healthcare setting, so everything is paid for. A lot of people go blind because they don't get to see the doctor soon enough. And it's just there are not enough doctors for all the people that are out there, especially when it comes to diabetic related diseases. For every person, we know we have like around 10% of people with diabetes. What often get missed is that for every person with diabetes, there are 3 people that are pre-diabetic. And you never know when they convert from pre-diabetes to diabetes. And there are simply not enough clinicians to look after all of these people. So we are sitting in a conference and we are chatting, and suddenly I realized that, all my experience throughout life has got me to this point, that I have the knowledge to come up with a technology that can scale up and suddenly replicate a retinal specialist in every clinic. So that was the beginning of Toku Eyes, ideally creating artificial intelligence that can mimic a specialist and automate a whole lot of things, because not every person needs to see a specialist. Out of all the people that walk into a clinic, about 10 to 15% of them really need to engage a specialist. A majority of people just need to be screened, and then they can go home and come back. So and during the past couple of years, I started to feel that it's a huge waste of everyone's time and opportunity and investment if clinicians are involved in screening. Clinicians should be involved in treatment. Yeah. So the whole screening part can be outsourced to machines, artificial intelligence, and doctors should really just be looking at people that need their attention. So that was the start of Toku Eyes. And by the way, people might ask, why Toku? What is Toku? So that's got a bit of a story. So at the very beginning, we were a team of 3. So my co-founder and another person that helped us start a company. So I'm Iranian, my co-founder is English, and the third person at the table was Singaporean. And we are sitting there in New Zealand. And we thought, okay, we have to have something that shows that we are from New Zealand.
Mhm.
So the indigenous people of New Zealand, they're called Maori. You might know them because of the rugby and the haka that they play at the beginning of a rugby match. So in Maori, Toku means my. So Toku eyes mean my eyes.
Mm.
So 3 immigrants sitting in a country in the middle of the ocean, we thought that sort of name would represent us. So that's,
There you
story.
are, the story. Well, I'm going to bring Atif to the table now. And Atif, tell a little bit about yourself and your background. I wanted to hear from Ehsan, a little bit, and then I wanted to bring you in to share a little bit about your background, and then ask some questions about what the technology he's presenting, the implications that has for healthcare.
Right. So thank you very much, Mary. I'm very happy to be here. I'm a medical doctor. I trained as an internal medicine doctor, and after that, after my residency, went on to do a fellowship in medical informatics, which is really the application of computer technology to healthcare, and served in the United States in Washington on President Bush's Advisory Council for Electronic Medical Records, build some national resources for educating the public about how electronic medical records are used, educating physicians, published about 25 papers, a book chapter, and also got about $25 million in grant funding for doing research in electronic medical records. After that, I left the academic practice to become an entrepreneur. And I have initially met a gentleman actually at a wine tasting who needed the help of a physician to develop a new diagnostic and treatment tool for cardiovascular disease. And I was very intrigued by his concept. We are basically using radio frequency ablation, which is a method of disrupting tissue using heating elements. We were going to use that technology inside the artery to basically dissolve the plaque that you have that builds up. And we have a technology that can also be used to image the inside of the artery using ultrasound. So we have married these two technologies on the tip of a single 1 millimeter diameter catheter. And now we're building a human prototype for testing. We've done animal studies to show the technology works. We can go through totally occluded arteries and in-stent restenosis and a bunch of other different conditions where we can open up these arteries without the need for bypass surgery or stents. So that's one technology. Another one that I'm a part of is a neuromodulation device that is a non-invasive device that you wear as almost like a hearing aid behind your ear. And it basically reduces the need for opioid medications and antidepressants and others. It helps treat chronic pain, anxiety, depression, sleeplessness, and a whole host of other conditions. So that device is ready to go to market, probably in the next 6 months. It's in the FDA approval process now, and it will help reduce the need for opioids. And given the world's epidemic in the opioid crisis, we can help mitigate some of those problems. So, and then I have a couple of computer companies. One is a device we're building that's a small tablet-sized supercomputer. It can do 5 trillion calculations in a second and only uses the power of a light bulb. So that device is, going to help in many different areas, including medical imaging, technologies, self-driving cars, home entertainment systems. We have many different applications for that. And then we have a miniature version of that as well that does about 4 billion calculations in a second and only uses 2 watts of power. So that's can run off of a battery. And the use cases for that device also are pretty interesting. So, I'm applying some of my medical background to tech and marrying it with technology to create very innovative devices. Mm-hmm. I'm also starting several venture capital funds. I have a venture capital fund called Silicon Nexus that's going to be funded here in the next couple of weeks. That will fund projects in healthcare. We'll also have a presence in sub-Saharan Africa to do treatment in the field. We're developing a device that will be able to do diagnostics in the field for capturing vital signs, doing blood work and lab tests without the patient having to go to the hospital. Our country is going to be in Zimbabwe, and we will initiate the project there. We have 400 nurse practitioners with access to about 1 million patients. And the idea is to use technology to treat those patients so they don't have to necessarily go to the hospital, which can be hundreds of miles away, and they don't have access to that healthcare. So that's one fund, and there'll be another fund that will invest in semiconductor technology and other things. So I have a whole bunch of different things going on, but delighted to be here and help with this review here.
Well, terrific. So Atif, what he shared so far, do you have any questions about how it operates and where they're at, anything like that, the impact potential?
Sure. So Ehsan, maybe you can describe a little bit about the technology itself. I read from the website that you're using deep learning to basically, first you're imaging the retina, and then you're using deep learning technology to potentially categorize the findings that you have, for example, the clinical findings that you see on the retinal images, and then correlating that with particular disease conditions.
Yeah, absolutely. That's probably the very best high-level review of it, and I should remember that to do it when I'm meeting with the VCs and partners. But essentially, you're right. So we are using retinal images. These images come from your optometry, your ophthalmology. Sometimes in primary care, they capture these images. And often you need a specialist to look at these images. So what we do we work with neural networks and we look at these images. And at the beginning, we focused on blindness because, again, that's where my focus was. To look at the very early signs of blindness that even a specialist might miss. Because, a specialist could really see after a certain threshold, they start to see the disease. We could look before that. So these are for very early and later on indications of a disease. And the work that we are doing, these are blindness. We are going through clinical trials. We finished few, and we are sort of submitted our application to FDA, and hopefully will become a medical device that we can use in this country. That product is already being used in 70 Indian clinics, so 70. We already registered product in Australia, New Zealand, and India. Essentially what it means is that now a lot of centers, they do not have an optometrist or an ophthalmologist. It is essentially a technician, a camera connected to our software. So the technician captures an image, our software quickly tells them within 15 seconds, it will tell the clinician, does this patient needs to go on and see an optometrist or ophthalmologist, or no, they can go home. So we're already making a huge difference in especially sort of low middle income settings when you don't have access to optometry and ophthalmology. I mean, it's really interesting that even in, India, we all know that there are problems. We all know there are sort of access problems, but even in Australia and New Zealand, that are Western developed countries, it is interesting that the low socioeconomic people, they don't have access to specialists, not without waiting for a very long time. Mm-hmm. So that's the sort of one part of the job that we're doing, one sort of aspect. The other aspect was that since we started doing and bringing that product into especially New Zealand, which is our home country, New Zealand sort of screening services, the New Zealand government asked us to look at a new opportunity. And that is to essentially use the same set of images, new neural network technology, to see if we can spot comorbidities and chronic diseases in the eye. So the back of the eye is the only place you can photograph your blood vessels. And it also, all the damage and all the risk that we've done and everything that we've done throughout life, it's captured in the back of your eye. So essentially, now we know, and we just finished our clinical trial, that using the images, the retinal images, we can tell if someone has diabetes, high blood pressure, cholesterol, hopefully soon chronic kidney disease, and if they've ever smoked. So we can tell all of that from a retinal image. So now we are in the process of bringing that. So right now, using that sort of data, we can calculate someone's cardiovascular risk. Today, if you want to calculate your cardiovascular risk, you have to have 2 blood tests, your blood pressure taken, go to see a GP. They will use these equations, the Framingham equations that Mayo Clinic uses or American College of Cardiology uses. You put your numbers in, it will give you a number. So for example, your risk is 20%. First of all, that is not accurate. We know that because the blood tests fluctuate over time. If you've been on a diet or whatever, you know, or if you had
things.
or if you have been partying for 2 weeks, that can throw off those blood test results. The other thing is these are population-based equations, i.e. they are designed not to be accurate. They are designed to essentially predict the average of a community. Mm-hmm. The clinical study that we are just about to publish shows that in our patient cohorts, and I will tell you about the cohort a bit later, but it's probably the largest cohort available. We are at least 25% more accurate than these equations. So if their accuracy was at the sort of 60% level, we are at 90% accuracy. So very, very accurately, we can tell if someone has a cardiac risk, and then we break it down to what is the modifiable part and what is the non-modifiable part. Non-modifiable part is your age, ethnicity, gender. The modifiable part is your blood pressure, glucose levels, cholesterol level, and medication, your kidney medication and all that. And so that's the product that we just released to the United States. So that's the part that gets me really excited, because now to me, it means that wherever you have a fundus camera in an optometry, ophthalmology, you know, in primary care, even in Walmarts or CVS's, these are places that these cameras do exist today. You can have your risk profile, the most accurate and most comprehensive risk profile. And it will then tell you that what you should be doing to reduce your cardiovascular risk. We know that if someone has a cardiovascular risk of, for example, 30%, and risk is like your mortgage, it accumulates over time. If your risk is 30%, you're bound to have a cardiac event, a heart attack or stroke in 5 years. There's no way getting around it. But for example, if you reduce your blood sugar level by 10%, the overall risk drops by 15%, which means that now the likelihood of having a cardiac event is in 15 years' time, not 5 years' time. So very small adjustments to a particular aspect of your health can have a very meaningful impact in your short and long-term health. That's the bit that gets me excited every day.
That's fantastic.
That's great. That's great. So in terms of these retinal cameras, you know, say you wanted to use this in developing countries, what is the, are there other modalities, for example, ophthalmoscopic exams that could be used to generate these images, or do you need some sort of a more capable retinal camera? What is, I'm just asking, what kind of quality images do you need to feed into your neural network for accuracy of prediction to be high?
That's a very smart question. That's when you know something about engineering, because neural network is one thing, but to make sure that whatever you created works with the minimum baseline sort of infrastructure out there, that's a whole other engineering. So let me give you the most comprehensive answer that I can. So there are a range of these cameras. They sort of go from $50,000, that's in your high-end optometric practices, to $5,000. These are very portable, very small cameras. You have some attachments that work on mobile phones. So you just put an attachment and it becomes a retinal camera. So they vary a lot. What I have seen in the field is that people try to use high-end images because these are good quality images, very well labeled, and you design a tool. And as soon as you get into the market, like low and middle income countries that don't have access to that hardware, it fails. So we put a lot of time and effort, and I can tell you with 100% confidence that our AI works across the board, because now we are getting images from rural Indian hospitals. And in those hospitals, we are talking about very rudimentary technology and internet, by the way. And we made sure that our product works in that setting, in that environment. I don't know, funny you should mention that, but yesterday we were just having this conversation similar to this conversation that we're having now with another company, rhymes with doodle. And they have been trying to do the same. They have been actually working on detecting diabetic retinopathy using fundus images in sort of similar setting in India. And they failed. They ended up rejecting 50% of images. So the neural network couldn't process 50% of images simply because it wasn't designed for that environment. Today, we reject 1% of images. We accept 99% of images that are coming from these machines. That's the part of the engineering that I'm really proud of.
Yeah, that's remarkable. So the applicability in developing countries is very high.
Absolutely.
And that, yeah, excellent. In terms of comparing with other ways of doing cardiovascular risk assessment that exist in, for example, developed countries, like calcium scoring is used, for example, in many of the developing countries. How does your technology compare with that in terms of predictive value, accuracy, things like that?
That's again a very good question. So usually the first risk assessment is done using blood test result and Framingham equation, which we know is not accurate.
Right.
If you get to calcium scoring, it becomes more accurate. But calcium scoring is very expensive and invasive.
Right.
Because it uses CT technology.
Yep.
We are even more accurate than the calcium scoring. And again, it's much less expensive, much more accessible, and at the same time, non-invasive. To me, access, this word access, is really important. It's probably the entire issue with healthcare system being in India or in the United States is access.
Right.
And access is about being cheap, available, not too complex, wouldn't break too easily. That's what it means to have access. My passion is to provide something that is accessible.
Right. Now, your neural network, does it run on the cloud or does it run in the local device?
It runs on the cloud, yes.
In the cloud. So you have to have an internet connection to be able to send the data. And you can probably do it offline. You don't have to have a real-time connection. You could potentially store the data locally and then upload it when you have an internet connection available. I'm thinking, we have a presence in Africa. Could we use this device there? And, with fragmented internet connections, and these nurse practitioners out in the field, they might have to go back to a hospital and then use that hospital system to upload the images and come up with risk scores. So, okay, great. Let's see. So in terms of looking at the retinal features, I would presume you're looking at things like neovascularization and cup to disc ratios and exudates and those types of features in order to be able to predict, the different things. So what kind of resolution you need to be able to basically accurately look at, these types of features on the retinal image? Do you need a high resolution camera or something?
No, that's a very good question. So the thing that the indications that you mentioned, like macroaneurysms, drusins, these are the ones that a human eye can see. So if I show you as a clinician, you'll spot them. And yes, we do look for them, but we also look for them that a human eye cannot see. So if I show you a specialist a retinal image, they wouldn't look for them. So we are talking about arterial venal nicking. That's how, for the audience that may not know, this is how the vessels bend. The crossing, so how they cross over each other, the thickness of them, the tortuosity. So, and very tiny color changes. So all of these that as a clinician, if you look at them, you wouldn't see them. So we're looking at all of those. So going back to your original question, the image should be about 1200 by 1200 pixels. That's like, I don't know, a megabyte, which is like not that high end really.
Right. So a typical cell phone camera can capture that image pretty accurately.
Yes. And we are working with a research group here in University of California, San Diego, and they are actually developing a sort of attachment for a fundus, for a mobile phone to become a fundus camera. And
Gotcha.
we've tested it, and yeah, seems reasonable.
Gotcha. Now, I looked on your website, you had two products, Thea and Oracle.
Correct.
Can you tell the difference between the two? What is
Yeah,
the
absolutely. Yeah.
You're getting a thorough.
Yeah.
device?
Yeah, no, absolutely. That's a
love
very
it.
question. So Thea is the eye product. It looks for
Okay.
blindness essentially,
Got it.
and Oracle is looking for cardiovascular issues, and we wanted
I
to
see.
differentiate them because one of them is very much optometry and ophthalmology,
Got it.
and
Okay.
the other one is primary care. Although you can have both, but we just wanted to differentiate the two.
Right. Okay. And so you would imagine the products being used in an optometry office to do screening, and then if the screening basically informs the patient that they need to see a specialist, then you make the referral. Is that sort of the use case?
With the eye product, yes. With the cardiovascular product, that's a starting point. So we start where the cameras are, but we are working with a company here in the States. They're called iCheck. So they are developing these kiosks, and they're gonna put it in retail locations. And you just walk up to the kiosk, put your chin on the chin rest, does what it does.
Wow. Okay.
We also, yeah, very much so. We're also working with another company called Unified Imaging, again, a US-based company. And Unified Imaging is collecting images from everywhere. It can be an optometric setting, primary care hospital, again, CVS, Walmart. So we're working with the sort of a group that are collecting images, and we run our analysis on images. The point being that it will be a direct to consumer, i.e. we have the images of your eye for whatever reason. Now there is this analysis that we can do, and we can very quickly tell you, if you should, take action on some aspect of your health.
So can you use this in acute care settings, like for example, in an emergency room setting where you might not have access to an ophthalmologist, and you have this kiosk or device that can capture an image and tell you if you have glaucoma because your cup to disc ratio is high, or you have a papilledema and it's might be a sign of a tumor, retroorbital tumor, or
absolutely,
those kind of conditions.
Absolutely. Yeah, so those are all very, very good use cases. And it feels like I'm pitching. I don't know if I'm pitching or not, but everybody that has looked at our technology has been amazed on the level of engineering, not just on the neural network side, but also, the very little infrastructure that it needs to work, which to me is very important. The main question is, how do you adopt it in practice? And you mentioned emergency units, optometric. That's the part that I'm working on today. So I'm working on, where does this technology valued most? Again, my aim is to make it available to as many people as possible, especially in low sort of middle income setting. Doesn't mean outside of the US. Even in the US, we are working with population that has very little access. I mean, the other day we were sitting in a conference, and they were saying that a majority of people they have such a high deductible, although they are insured, they are really not insured just because they don't afford their deductibles. So that's the population that I really want to go for in this country and around the world.
Gotcha. What other conditions do you think you'll be able to predict using this, maybe in the future? Are there other conditions, that might be amenable to this?
That liver.
So no, that's a very good. Well, we can't tell if you have high cholesterol. So if your liver hasn't been doing this job, we can tell. So we are adding chronic kidney disease. That's the one that we are actively working on. We are also moving into OCT. So OCT is another modality for imaging the eye. It's a bit different on this imaging. And that will be more about neurological diseases. We are talking about Alzheimer's, dementia, those diseases. Again, the back of your eye is the place that is directly connected to your brain. So the optic nerve is the largest set of axons that comes from your brain to your eye. And if you can visualize it, essentially visualize your brain.
Right. So you can, with OCT, you can actually do a three-dimensional kind of image?
Yes.
you can get depth information along with the retinal
Exactly.
information. Okay.
And it's all about axons, and it's all about how the neurological diseases change your sort of neurological system.
Gotcha. Okay. Very, very good. Let's see. When you use this for your cardiovascular risk assessment, is the methodology to kind of use surrogate markers like hypertension and diabetes in order to predict the risk, or do you measure some other?
Nothing.
Nothing. Okay.
Nothing. We take age, ethnicity, gender, and the retinal image. That's all we take.
Okay.
The idea is that the technology should work by itself. You should, as a layperson, I mean, how many people know their glucose level? I don't, really, I don't, right? But I can walk up to a camera, have my image taken.
Right.
Again, it's all about access. It's all about removing whatever is not essential.
Right. Can you look at other features inside the eye other than the retina? You know, the opacity of the globe, or, you know, certainly you should be able to pick up cataracts, other kinds of things with this, the size of the cataracts, and, you know, other kinds of features in the eye itself that might, you know, be amenable to risk assessments or other things.
Yeah. So that's actually, again, a very good point. So yes, for example, we do see opacity of the anterior segment, like cataract or any corneal damage. We do see it in an image, and we do flag it as in, like, this person seems to have cataract. But again, that's something that then needs to be referred on, and a clinician should be looking at it. But yeah, we do see that.
Can you look at the opacity of the globe itself? For example, if your image is blurred, it might suggest that there's high blood sugar, active high blood sugar, because you're not getting a clear image, and the aqueous humor is more, you know, opacified because of the high blood sugar. Are you able to tell that level of detail, or is it just mostly focusing down on the retina?
Not from opacity, but we do see diabetes in the retina. It's really interesting. That, you know, people live with diabetes and never think that they are diabetic. That's the part that gets me, that many people, they don't think they are diabetic while they are diabetic. And when we tell them that they're diabetic, they wouldn't believe it until they do a blood check, and it's often a surprise. They're like, I didn't know that I'm diabetic, because again, how many times do you go and get your blood check done?
Right, exactly. Oh, excellent. Yeah, excellent. Let's see. Did I have any other questions? In terms of adopting this, for example, in developing countries, what do you think might be a typical cost estimate for, say, someone who's a provider, a nurse practitioner who needs so other than just a retinal camera, is that all you really need in an internet connection, I would imagine?
Essentially, yes. So essentially, so the only upfront cost, which by the way, we are working with few partners to even get away from the upfront cost and make it like an ongoing sort of lease sort of setting. So the cameras are not bought, they're leased to owned. That's the only cost, really. That is the only cost. I mean, we do have our own cost, which is usage of cloud, but compared to all the other bits, it's relatively minimal.
Gotcha. So the images get sent to the cloud, and then they get evaluated there, is what I'm going to imagine.
Correct.
And I'm sure you have, you know, HIPAA compliance with that, with privacy and, you know.
I was going to ask about privacy. Yeah.
Secure,
yeah, absolutely.
And all the other kind of features that would go into it.
Yes. So we made sure that we are compliant with HIPAA. We are ISO 13485 certified, which also means that we are at the medical device level. All the audits, all the, you know, everything that we do is audited every 6 months. So yeah, it's really important to do the right thing, because what I don't want to do is to create a tool that then for some regulatory reason cannot be offered. That just doesn't sort of defeat the purpose. So
the data that's generated from this, is it fed to the patient, or is it fed to the primary care doctor that they see, or both, or how do you?
That's a very good question.
That's what I was going to ask.
Very good question. Yeah. So we present the data 3 ways. The first one is to the patient, i.e., here's your risk. These are the components of your risk. And you really should focus on this one, like the top one, which is, for example, blood pressure, to get the maximum out of sort of your reduced risk and your efforts. So that's number 1. Number 2 is to the clinician. To the clinician, it's more about the improvement, i.e., this person, if we had access to previous images, the risk was X, now it's something else, and what happened between the two in a 6 or a year, so 6 months to a year sort of time lapse between the two images. And then we provide the sort of a population-based information to the payers, i.e. the cohort of people that you see, this is the risk profile. And these are the sort of a 5 to 10% of people that you should really focus on, because these are going to be the most expensive ones. And if you delay any set of events in them, cardiac events in them, it's going to be a significant savings for you as a provider.
Gotcha. Now, I'm going to wear my entrepreneur hat here and ask you, actually investor hat, what kind of, you are looking for funding to expand into different countries or to build technology? What is your next sort of step in developing your company?
Sure. So we raised $2.5 million last year, and we also got $2.5 million from the New Zealand government as a non-diluting fund. They have been extremely generous to us. So this time around, we are asking from $7 to $10 million. So there's a sort of a range there, and it will be about expanding into the US market and Indian market. Those are the two markets that we are really focused on. I always thought that we are a social enterprise. So you make money somewhere and you sort of invest somewhere else, if that makes sense, because again, I want to make a difference in this world. And part of the money is to grow into these two markets. Another part of the money is to engage the regulatory system, especially FDA. As of today, our cardiac product is considered a wellness product, like your Fitbit. It does give you information, but it doesn't give you a referral. However, I want to make it a medical product. So eventually it will refer you to a cardiologist or nephrologist or diabetologist.
Gotcha. Are you guys open to working in other countries? Like, for example, we're working in sub-Saharan Africa. Is there, there could be funding associated with that, and both from the government and from our own fund that we're raising. So there's a possibility of working there and, doing trials and, using inexpensive, say, retinal cameras that can be attached to a phone, and then, working with nurse practitioners. I think there would be a lot of interest with the people that I work with. Maybe engage in something like that.
Absolutely. Again, going back to my story, there is no point serving the people who already have access to health, right? And I want to make a meaningful difference in this world. I know it sounds cliche. I'm sorry if it does sound cliche.
I have the same. I have the same mission.
We're all
everything I do is somehow helping humanity. So every project I have somehow helps
exactly.
Humanity.
It's just. I think about my own father, right?
Yeah.
I think about my own father, and there are millions of people like my father, like children or young adults or even adults around the world. They're here in this country, in the US, but they're everywhere. So to answer your question, absolutely. If we can do something meaningful in a country that has almost less than nothing, then I would happily do that.
Okay. There may be I may be calling you after this. So we have a new fund starting up that's fairly substantial fund, and so I think we could potentially work with you guys on something.
Love to help.
More conversation to follow, sounds like.
Right.
Yeah.
Right.
Ehsan, you might have mentioned this before, but you hinted at it. You wanted to talk about the clinical trial that you have this largest pool.
Sure.
Can you share that just a little bit?
Yeah, absolutely. So again, this is the help of the New Zealand government. So in New Zealand, we have a public health system, which means that all the patient information are gathered in one place, which doesn't exist in this country, which is surprising to me as a foreigner. The New Zealand government essentially gave us access to about 500,000 patients that are tracked over 10 to 15 years. And every single interaction with the health system is captured. These are retinal images, every single drug dispensation, every single blood test done, every single cardiac event or other events or mortality, if there was a case. So we were given the information, we were given the funding. So the tool that we have created is probably the most accurate tool ever, because I don't think there is such a database available anywhere else. So there is the other database.
The envy of other founders of health technology innovations.
Yeah, and for example, there is this UK Biobank. People in the field, they know about UK Biobank from that NHS, because NHS is sort of a similar system. So we are using that as our test. So whatever we do internally, we test it on the UK Biobank. But the UK Biobank, the quality of the data is not that great because of how NHS works in particular systems. But again, we have built a tool that, as an academic, not as an entrepreneur, as an academic, I believe it's the most accurate tool that can exist out there. We put a lot of engineering into it to make it available to low socioeconomic places with minimum technology, like minimum infrastructure. That's the bit that I'm extremely proud of. As an entrepreneur, I have to look at the accounts. I have to make sure that everybody gets paid. That's the bit that, you know, causes this gray hair, I guess.
I love this right here. Awesome. Well, that's great. I think other than what you were looking for, which Atif was able to draw out about the next level of investment, are there any other types of resources or people that you might be looking to connect with?
Oh, that's a very good question. I think, again, because I want to get in front of as many people as possible. So Atif mentioned collaborations in Africa. Fantastic. We're already working with the SEVA Foundation, SEVA.
Okay.
That's the largest sort of NGO sort of institution, mainly in India and Mexico and few other countries, and they provide eye care. So we are very much involved with them. In the United States, I think we are lacking that because of how fragmented the system is. And it's like there are 200 providers and each of them have their own sort of system. I think, to your question, Mary, getting partners that can get us into the US market as soon as possible, as fast as possible, I think that's where I'm lacking. I mean, again, one thing about low middle income countries is that at least there is generally one provider, generally speaking. That's the government mainly. There are lots of NGOs that work with the government, but in sort of Western world, you run into the problem of 200 different insurance companies, and then each of them have their own policy. So that's the part that we are sort of struggling right now.
Okay. Atif, any final words from you?
No, I'm delighted to meet you and looking forward to learning more and hopefully working with you in the future.
Absolutely, Atif. Again, at the beginning of this conversation, I thought I'm the hardest working person in the room. Apparently not.
Yeah, but you're not alone, right? You're not alone. Well, thank you, gentlemen. This has been an enriching conversation, and I'm sure you feel so, Ehsan. And Atif, wonderful, flow of conversation and good questions, really good questions. And
Absolutely.
I learned a lot myself through this. My grandmother she was blind for most of her life until she passed away. And amazingly, it made her brain stronger. She was 100 when she died, and she could remember things I would never be able to remember. But completely blind, glaucoma. My husband has glaucoma, so I totally I get it. What you're doing is just really, really valuable from the standpoint, not just the blindness piece, but also every little thing else. The chronic kidney, the diabetes, everything. Cardiovascular is just, and I'm like Atif, I don't think I see the end right there. I think there's more.
Oh, yes, absolutely.
With that. And I believe it. So I think investing in something like that is just an amazing, journey into creating impact. So I'm going to leave it with that. And you guys stay on for a minute. I'm going to say goodbye to everybody else and say, if you're watching this on YouTube, go to www.frontrunnersinnovate.com. You're going to see the entire interview. A little bit about his bio, Ehsan's bio, a little bit about Atif, and we'll have links, whatever they'd like to provide with us. Atif belongs to, 100 different entities. So we'll put links to what he provides for us. And also, Ehsan, you'll get to find out a little bit more and visit their website at Toku Eyes. So thank you very much, guys. I appreciate it. You stay on. Bye, everybody. Happy front running.